Firstly, I'd like to welcome you all to this, our 9th Success Conference, which shows that time passes quickly. A day of opportunity, I hope, for learning, networking, enjoying each other's company, for the survivors to build links with, and reaffirm their links of camaraderie with each other, and to, above all, take Success's work forward. Now, as you will all be aware, or perhaps some of you aren't aware, the title of Success for this charity is a sort of slightly double-edged sword. I've never quite examined the psychology behind it with Helen, but I did get the impression that when the title was chosen, it was in part a slight rebuke to the National Health Service that their idea of success was a bit of a tick box. Whereas Helen's idea of success for this charity is something more fundamental. And above all, that the success should be sustained. Because as you'll be aware, the NHS tended to rate success simply as to whether the operation to remove a tumour had been successful and not the aftercare. And so Success's purpose has been to try to develop that aftercare and take an approach that goes right through the lives of survivors. And the extraordinary thing this year is, after a lot of beating at doors, and we have beaten at quite a lot of doors over time, we have achieved our first really significant success. 20 years of campaigning, and we have finally succeeded in persuading the NHS of the absolute necessity of having continuing care for remediable and unaddressed acquired neuroendocrine brain injury. And that has been recognised by our being included in the NHS cancer plan for neurorehabilitation and the provision of a care worker or care person in order to help people through that. So this is an amazing change, because I have to say, since Helen persuaded me to start coming along and being the patron of this charity, I have at times felt that we had a very uphill climb. But this is, I think, the first really significant change. Now, there's lots of other things to do. We want to get on with our digital therapy provision. We want to make sure that the pituitary tumour service for children and through into adulthood, a very limited number, but nevertheless important, is taken up by the NHS, and that there is a single point of contact in order to help those children through the process. And we've got lots of other ideas of things that we want to do. But today is, I hope, a celebration of a bit of success, as well as looking forward. And as I say, an opportunity above all to listen to some very knowledgeable people. As I know almost nothing on this subject apart from what Helen has told me, I tend to just sit at the back and find myself better informed by the end of the day. So, with that in mind, I would like you to welcome Helen to the stage and to give her an enormous round of applause, because after all this effort and setting up a charity which has zero overheads, but nevertheless uses its money wisely, she has achieved her first goal. And thanks in great measure to your support of this charity simply by being here. Thank you very much. Helen, come on up. So, you've done it. We've done something, haven't we?
We've done something. It's a huge achievement, I feel. In fact, I would go as far as saying it's the pinnacle of a 50-year career in the NHS since I became a student many, many years ago, because I used to look after, as one did in those days, paediatrics was a holistic service. And we were all trained generally, we all knew about the whole body, we all knew about growth and development, and we increasingly subspecialised thereafter. And so some of these children who we looked after and actually gave the chemotherapy to. We didn't have all these fancy systems, and I did my research in the effects of radiotherapy on the childhood brain when you had a brain tumour. And that was 25 plus years ago that I became a consultant. And at that time, children with brain tumours were not receiving chemotherapy. In fact, some of them were not getting any treatment at all, particularly if they were very little, as it was thought that they would be inoperable and die. And what we've forgotten is that many didn't die because the tumours were not cancers and the effects were of pressure on the brain. And eventually doctors were forced to give radiotherapy and they survived. And then they blamed all the treatment effects that we call late effects on the effects of the radiotherapy without thinking about what damage the tumour had done beforehand, the late diagnosis and the lack of appreciating a brain injury. And so there was an attempt 25 years ago, was NICE guidance. The first NICE guidance NICE ever did was the guidance on children and young people with cancer. And on it, I was a representative, and I fought hard to get brain tumour children on that. I said two things. They're not all cancers, but they get cancer treatment. And the difference is they are different from other cancers because they're in the brain. And we knew at that time that that was likely to cause a brain injury. And we got on the cancer guidance, every child and young person who's had a CNS, a central nervous system tumour of the brain or the spine, is likely to need access to a multidisciplinary rehabilitation team, which we know works, which we know is cost effective, and it may be lifelong. That was 2005. In 2012, they reiterated it. We had the big push for adult brain cancer, and adult brain cancer got a proper specification, and they understood about pituitary tumours in adult brain cancer because pituitary tumours are actually benign. 95% are cured in their terms, and all cure means is 5-year survival. Doesn't tell you how you survive, and it's not a very good statistic if you haven't got a cancer in the first place. So we've been using a cancer model, and we have not been appreciating the rehabilitation needs, both endocrine, mental health, and neurorehabilitative and educational, on a child with a brain tumour. And that was all assumed to be a late effect of radiation. And as many of you will know, when you've had your consent, you're told about all the things radiation will do. And chemotherapy is going to save the day. And actually the bit that is difficult to say in front of oncologists is that after 25 years, chemotherapy didn't save the day for those that are not cancers, and actually added to the toxicity. And I think the idea that you would wait 5 years for a treatment to end before you then bunched all children into a late effects service where their needs were just monitored and assumed to be treatment related, and a lot of them are if you've had chemotherapy, ignored the fact that there was an injury to the child's developing brain, missed developmental opportunities until they were too late in adolescence and gaps had accrued and it was difficult to reverse them. And I began to feel this was unethical. I thought, how can you promise a cure of the brain tumour without actually promising a cure of the brain injury? And how do we know what is a treatment effect without knowing at the beginning what has been caused by the tumour and what has been caused by the treatment? And that's why I felt all along if we had a key worker and an assessment, not just the key worker, there were 7 other bits in that cancer plan that we didn't get through. We should be able to do these assessments and then we'd know what was treatment related and what was injury related, and we would provide the child's developmental, educational, hormonal and neurological requirement at key stages of growth alongside education, key stages of development, so that they could regain their futures as an adult. So that, the success of the cancer plan, I couldn't have done it without you and your voices. I couldn't have done it without the parliamentarians. I couldn't have done it without setting up the charity. You gave me the mandate. You gave me the platform. I couldn't persuade the NHS otherwise. And this is a huge first step.
Now, we have a national cancer plan. How do you see that in terms of what success might get from it? Threat or opportunity? How do you see that?
So the threat is that we allow what happened previously in the NICE cancer guidance to continue. In other words, the recommendation was there. Children should. Didn't say they must. And nobody can persuade trusts, clinicians to deliver these services. We're always fighting a big cancer lobby. The word cancer has a huge impact. It brings a huge money behind it, the cancer plan, cancer MDTs, and neurorehabilitation and neurodisability and brain injury are not words that people want to hear. And certainly parents do not want to hear that their child may have a brain injury, and that's been quite difficult. We've only recently been saying that, and some of you here have had difficulty with that. But there are many forms of brain injury, and these are focal injuries, and we have to create some research around them. It's very glamorous to have a research protocol in molecular biology or drug development. It's not glamorous to have a research contract in late effects. Late effects services are not consultant-led. And they don't have academic people behind them. But we could create something that has a huge opportunity to develop careers, to develop research. And my biggest gripe with research is that people do the research, they get the PhD, they get the gong, the publication, and the service runs for 2 years, and then it's all abandoned when the money dries out. And putting that research to become a service implementation is impossible. So what we want to do is actually deliver applied implementation research. We want to develop academic partners and pilot our vision for the recovery pathway and co-design with academic partners the elements that we think make up that pathway. Neuroendocrinology, which is basically the pituitary that drives everything that not a lot of people really understood, but it's actually the basis of survival itself, growth and development. And it impacts on the brain. The brain's a very important organ. If I had my life again, I'd study it. But I've learned a lot from my neuropsychology colleagues, and I want to learn a lot more from my neurodisability colleagues. I haven't had access to them in all my career, and I know that's a patchy geographical thing. We want mental health. People think neuropsychology and education and IQ is the only thing that we've been monitoring in brain tumours. Actually, there's an enormous amount of undiagnosed mental health, serious mental health conditions, not just well-being, which is today's problem. I've had a lot of young people say, when I went to a mental well-being seminar, I thought, they call that mental health? And we got to do the health economics case to show that actually implementing services that recover a child's brain from the beginning throughout the developmental phases into adulthood and beyond will actually save lives, save costs, save health burden, get more young people into employment, and actually save the public costs in the future. And actually, isn't that what a cure is?
And targets for success for the coming year?
So, well, I always run before I can walk.
Yes.
And I try and catch as many rabbits as I can. So focus is not my strength. Determination is. So I need people who can help me focus. I'm looking for people who are wanting to make partnerships with us, who have skills and strengths that we don't have, who are all high level to help make us grow this, because I don't have that expertise. But I've been terribly encouraged that we have people here, that there is a calling, that our oncologists have heard us, because we wouldn't have got that through the cancer plan if they hadn't heard us. So I think what we want to do now is grow what we have. We're already delivering elements of the pathway that the NHS will never deliver. The social aspects, the community aspects, the Brave Hearts programme that we call it, our online groups. We're national. This is NHS England, but we're hoping NHS Wales, NHS Scotland, NHS Ireland, and we've got Irish representatives here, will follow. Because this is we're a nationwide charity, and the NHS is a peculiarly British institution. And I want to make sure it's for every child, including the disadvantaged, the immigrant populations, the cultural ones. When I was on the NHS, I saw everyone, because everyone who has a cancer is brought to you for treatment. The police will call the door. They will go to your door and bring your child for treatment, but they will not do it for rehabilitation. And there are a lot of people here. Those of you who are here are the converted ones, but there are a lot of people out there who do not know and cannot access. So we're looking to try and grow this, and also really develop the key specialist areas. And we're looking for one very special person who can lead a steering group and help us coordinate that on our panel. And of course, we're looking for funds. So our way to try and think about funds is to work with NHS England commissioners, with NIHR, with academic funding partnerships to do implementation research. But we do also need a lot more to grow beyond, because we're a tiny charity, tiny, and we've taken on Goliath, and we've won. But now we've got to continue.
Thank you, Helen.